Hi gang, how we doing? Here we go again. Good morning, good afternoon, good evening. Let's get into the second half of pathophysiology. Again, my name is Mike Biamonte, manager for the FBI School of Operational Medicine. Get my disclaimers out of the way. Nothing classified, nothing sensitive. Hope everybody's enjoying it. So far the feedback has been very, very good. I'm happy to see everybody's enjoying it. We left off last class with actually a few people had questions, and let's start with the questions to get those out of the way. The music at the beginning and the end of this is from Yo-Yo Ma. All right, we'll get that out of the way. What I'm wearing, other than a polo shirt, while I'm sitting here at this desk, is nobody's business. And I drink three things. I drink water, I drink coffee, I drink Jack Daniels. I've had two of the three this morning, so it's up to you to figure out which others I've had. This is water with juice, by the way. Nothing else. So yes, I just contradicted myself. All right. We left off with pathophysiology last time. Part one. Advanced stuff. We left off with the renin-angiotensin-aldosterone system. You can talk about that stuff for days. It's really quite complicated, but I'm trying to keep it as simple as possible and keep it applicable to our level, whether it be when I say level, EMR, EMT, AEMT, paramedic, I mean the pre-hospital level. By no stretch of the imagination am I a doctor or ever claim to be a doctor or nearly as smart as a doctor. However, I try to keep things in the perspective or in the scope of practice of the pre-hospital setting and what we need to know to make us more effective. So when we left off, we were talking about fluid balances. And with fluid balances also come inherent problems with electrolytes. So let's talk a little bit about electrolytes and what they are. So let me go ahead and put this screen up here on the, or this picture up on the screen. This is just a quick roll of electrolytes: calcium, potassium, magnesium, sodium, and it talks about chloride. I don't really put too much emphasis on chloride. I think about the big four, and the big four, in my opinion, is sodium, potassium, calcium, magnesium. Those are the four big ones. By definition, electrolytes are molecules that form ions when dissolved in water. That and $2 will get you a cup of coffee. In all the classes I've ever taken in college, we've gone over electrolytes and that definition, and it's always confused me. But what I do know about electrolytes is how unbelievably important they are to the normal functioning of our body. Cellular activity, muscular activity, brain waves, neurological impulses, everything. Something as complex as, or think of it this way, something as simple as a heartbeat. Just for your heart to beat one time, to contract once, takes a fantastic amount of electrolyte movement from sodium, potassium, calcium. It's fantastic what happens at the cellular level when we talk about just a single heartbeat, let alone nerve impulses. The sodium plays a huge role in that. Calcium plays a huge role in muscular contraction. As an example of how sensitive we are to electrolyte imbalances, potassium. Don't quote me on the number. I want to say the number is 3.5 to 5.3 on a lab slip. It's a very narrow range of being normal in our body. But if we get too much potassium, hyperkalemia, our heart stops dead as a stone. Case in point, lethal injection. One of the syringes in lethal injection is a syringe full of nothing but potassium. They inject that into your victim, your patient, whatever it is you want to call them, and their heart stops dead. When surgeons are doing open heart surgery on a heart, well, they don't want to work on this thing while it's beaten. So after they put a patient on a bypass machine, they'll bathe the heart in a potassium solution, stops the heart so they can work on it, and then they restart it afterwards. Hopefully they restart it afterwards. So potassiums are just tremendous in what they do and how they affect our body. People have asked me, and I've entertained this question, as has most medical providers. How do you maintain a normal fluid balance? How do you maintain a normal electrolyte balance? Do you drink Gatorade? Okay, here's the long and short of it. stay well hydrated. And everybody has seen those hydration scales as to what color your urine should be, if you're drinking enough, so on and so forth. If you're peeing clear, you're doing all right. Now, does that mean it's 8 glasses a day, a gallon? I don't know. Whatever it takes to hydrate you. Should you be drinking straight Gatorade for dehydration? The answer is no. It's too powerful. There's too much sugar in it, quite frankly. Cut it in half, 50-50. Preventive medicine is the best medicine when it comes to preventing dehydration and fluid depletion during strenuous events. When we talk about electrolyte imbalances, proper diet, just eating good food, and 9 times out of 10 your electrolytes aren't going to be an issue. But if you are in an extreme situation, physically speaking, hot environment, yeah, you do want some supplemental electrolytes, and a half concentration of Gatorade in your water typically does the trick. How do you identify somebody who's having electrolyte imbalances? Well, on the bottom of this slide here, you can see just a broad stroke general terms of confusion, changes in heartbeat, anxiety, muscle spasms, digestive. Yeah, okay. Everything under the sun could be a sign and a symptom from electrolyte imbalance. What are the 2 biggest reasons or 2 biggest culprits for electrolyte imbalance? Nausea, vomiting.
That's from the bake sale that Lois was... Oh, one down. I know somebody who won't be having any...
I'm starting to feel funny.
Well, I feel fine. I guess I'm gonna...
Oh, boy! That means I win! I get to eat...
We talk about nausea, vomiting. Well, that paints a pretty clear picture. You have somebody, extreme vomiting, diarrhea... Those are the culprits. You're dumping a lot of electrolytes. Sweating is going to do it as well. So just kind of think about that when you're dealing with patients who are sick and possible electrolyte imbalances. What can we do for it pre-hospitally? Quite frankly, very little. There's very little we can do. We could identify it or possibly identify it, have a high index of suspicion for it, maybe start some normal saline as a rehydration attempt, but even that is really just scraping at the surface. So there's very little for us to do other than get them to a hospital and get them proper care. So let's go ahead and pull this screen off. And let's move on to acid-base balance. This tends to be quite the, I can't get my slide to change. There we go. This tends to be quite the challenging topic, especially at the paramedic level. When we start talking about acid-base balance, how does the body regulate it? What are acids? What's the normal range? How do we identify somebody who may be out of whack with their acid versus their base? Are they alkalotic? Are they acidotic? A lot of big questions come up with this. At the pre-hospital level, again, there's very little we can do to identify those people who have an acid-base imbalance. We can have a high index of suspicion based on how they present. We can have a high index of suspicion based on their medical conditions. But at the end of the day, there's very little we can do. The normal body range. So if you look on this scale, 0 being battery acid, 14 being liquid Drano or liquid drain cleaner, we hover at 7.35 to 7.45. So 0 is very acidic, 14 is very basic or very alkalotic. I think of us as human beings as being very basic creatures. Stupid, I know, but that's how I remember it. So when we talk about 7 being water, that's as neutral as they come. We are fairly basic creatures. We are 7.35 to 7.35 to 7.45. But on a pH scale, we look at it as, okay, well, what's the big deal if we went from 7.35 to 7.1 or 7? It's not a big deal. Well, no, it actually is. For every 1 step on a pH scale, we're actually bumping 10 notches, if you will. So let me go ahead and put this other slide up and take a look at this, just to give you an idea as to how narrow the range is. We said we're 7.45 to 7.35. Well, Um, Anything less than 6.8 could be death. Anything greater than 8.0 could be death. So when we're talking about pH changes in the body, we're really talking about very subtle movements, or so to speak. We're not talking about, okay, yeah, it's only one notch, not a big deal. Yeah, one notch is 10 steps. That's a really pretty profound problem. So what is pH? pH, moles per liter, parts per hydrogen. I've heard it described a couple of different ways. Basically, if somebody, when we talk about acids versus bases, being acidotic versus alkalotic, an acid is something that donates hydrogen ions, and a base is something that absorbs or receives hydrogen ions. Okay, that's all well and good. For our purposes in EMS, I want you to think about carbon dioxide as an acid. Let's keep it simple. And then there's lactic acid, there's pyruvic acid, there's all kinds of different acids in our body. But let's keep it simple for us. When we talk about somebody not breathing well as an example, and we're going to talk about respiratory acidosis here in a minute, the exhalation and the getting rid of carbon dioxide by breathing out and exhaling, that's imperative, or one of the steps is imperative for us to be able to maintain a normal pH balance. We we balance and we regulate and compensate and balance our pH by three different mechanisms. Chemical mechanism, a respiratory mechanism, and a renal mechanism. So let me put this next slide up here. And what you're seeing are three different ways that we, as human beings, we regulate our pH. First one is called the chemical way, right? The carbonic acid bicarbonate buffering system. Big term, very, very complicated topic, but at the cellular level, as we sit here right now, as you sit here listening to my nasally voice and I sit here spewing out this information, our cells are constantly regulating pH. As a normal byproduct of cellular metabolism, we produce acid, pyruvic acid, lactic acid. It's normal. That is what we do on a regular basis. And at the same time we produce it, almost within fractions of a second, our body breaks it down and neutralizes it to keep us at 7.35 to 7.45. Just a miracle of biology, quite frankly. So as we sit here right now, calm, under no stress, hopefully calm and under no stress, I don't know how you're watching this, we are naturally breaking down acids, converting acids, and keeping us at a normal pH for our body, keeping us homeostatic. Well, what if we become a little overloaded with acid? So let's use this as an example. Let's say that you walk into a gymnasium. You don't run, you haven't PT'd yet, you haven't done anything physical. You walk into a gym, you lay down on a bench, and you pump out 10 reps of a pretty heavy weight, and you put that bar back on the rack and you sit up. Chances are you're going to be, you're going to be breathing a little heavy. Why? You haven't done anything. You haven't run, you haven't walked, you haven't done any cardiovascular exercise to make you winded. Well, what you've done is you've started to require more effort from the muscles of your chest and your triceps and back and so on and so on and so on. So the tissue, the muscles, and the cells of these muscles are requiring a lot more oxygen. And for a fleeting moment in time, you're not able to provide that muscle with enough oxygen to maintain normal aerobic metabolism. So for a little bit of time, the chemical buffering system of your body gets overwhelmed, and the normal cellular metabolism cannot break down and process the lactic acid that's being produced by your muscles. Well, what kicks in? Well, your respiratory system. Your respiratory system in this aspect is also called your protein buffering system. Well, now we start to breathe hard. And what we do is we help the body's cellular metabolism blow off acids by breathing, which is normal. So when you're running, PTing, walking up and down the stairs, For me, rolling out of bed in the morning, I'm exerting myself and I'm getting a little winded and I have to breathe a little harder to blow off those acids in order for me to maintain my pH. So let's take somebody who's a victim of trauma, shot, stabbed, whatever. They have done nothing. I mean, obviously they're upset. I'd be upset too if I got shot. But they're lying there bleeding. Well, now they're bleeding out. So what's going on deep down inside at the cellular level? They're starting to go into anaerobic metabolism because not enough oxygenated blood can make it to the tissue. So how does the body compensate? Well, your normal cellular metabolism is becoming overwhelmed. So what kicks in is the respiratory side of the house. And that patient starts to breathe hard and fast. And when you're talking to them, say, hey, buddy, how you feeling? Yeah, I'm all right. I'm okay. I'm a little, And now you notice they're getting cool, pale, diaphoretic, and they're starting to breathe a little faster, and they're getting tachycardic. And we're going to get more into that later on in this video. But this is the body's way of starting to maintain the normal pH of our body, which is really pretty cool. So once your chemical buffering system becomes overwhelmed, and once your respiratory buffering system becomes overwhelmed, well, now your kidneys start to pee out and get rid of acids. This is a very late in the game kind of compensatory mechanism. Your chemical buffering system at the cellular level takes place in seconds. You don't even know that's happening. Your respiratory buffering system constantly helps, or just by us breathing, we're constantly helping the body. But when we start to become tachypnic, and we start breathing hard and fast, that's going to happen within a few minutes to be able to help cells do their job. By the time we're peeing out acids, now, not to say that your pee is going to burn, that's a whole different conversation. But by the time our pH of our urine starts to change and become more acidic, that's days later. It really is. It takes a while. So it's not something that we're going to see in the pre-hospital environment. So let's talk a little bit about different types of acidosis versus alkalosis. Let me go ahead and change the slide again. Let's look at this slide. We have metabolic and respiratory issues. Now, this is, again, a source of huge confusion at the paramedic level. When we're talking to paramedic students or paramedics who are trying to wrap their head around this, and sometimes there'll be this scale, and it'll, if this happens, well, then the equation slides to the right, and if this happens, the equation slides. Don't worry about that equation. That's all crap, all right? Keep it simple. Your body, when we talk about acid-base balance, 7.35 to 7.45, just to reiterate, we compensate 3 different ways. Our cells do it naturally. We have no control over that. After our cells become, or as our cells become overwhelmed, the respiratory or the protein buffering system kicks in and we start to blow off acids, CO2, lactic acid. We'll talk more about that later. And then finally, the kidneys start to kick in days later. But again, that's nothing for us to be concerned with. Your body can only suffer from respiratory or metabolic acidosis or respiratory or metabolic alkalosis. That's pretty much it in a nutshell. So when we look at the two, let's look at acidosis real quick. For somebody to become, or for somebody to suffer from what's known as metabolic acidosis, a few things have to happen. Maybe they're in renal failure and they can't get rid of urea, ammonia, urine in general, and get rid of a lot of acids. Maybe they've had an intake of an acidic substance. They've ingested some sort of acids. Maybe they're suffering from lactic acidosis. We talked about this earlier, from either excessive physical exertion or hypoperfusion. We'll talk about hypoperfusion here later. They could also be suffering from DKA, diabetic ketoacidosis, alcoholic ketoacidosis. We'll talk about that when we talk about diabetes. But here is a situation when we talk about the Atkins diet as an example. If you deplete your body of sugar, well, the body is going to turn to fat for energy. And in breaking down fat, we produce what are known as ketone bodies. As these ketone bodies build up, we now convert ketone bodies into keto acids, and our body becomes acidotic, and we suffer from diabetic ketoacidosis. This takes days to weeks to happen in the extreme diabetic. But this is one of the things about the Atkins diet that was always high on the radar. Oh, you're walking around in a constant state of acidosis, which to a certain degree was true, which the body doesn't like. So what if you're suffering from respiratory acidosis? Okay, let's take a heroin overdose as an example, or some sort of fentanyl overdose. One of the biggest things we're going to see with any kind of opioid overdose is respiratory depression. So these people go from normally breathing 12 to 20 times a minute now to breathing about 4 to 6 times a minute. And what they're not doing effectively is blowing off carbon dioxide. So as I said before, carbon dioxide is an acid in our world. Think of it that way. So if they're not able to blow these acids off, well, now they're suffering from respiratory acidosis. Very easy to fix. All we got to do is stick a nasopharyngeal airway in their face, bag them up, and blow those acids off. That's it. It's an easy fix. And of course, Narcan comes into play, and we'll talk about that later when we talk about pharmacology. So alkalosis, metabolic alkalosis. Well, let's think about Peter and Stewie and the vomiting Family Guy episode. If you're getting rid of all of your acids, gastric emptying as an example, whether it be vomiting or nasogastric tube or whatever, or you've taken this huge intake of Tums or some sort of antacid, well, now your body can go into a status of metabolic alkalosis. When we talk about respiratory alkalosis, we're talking about somebody who's breathing too fast. They're hyperventilating. And what you'll see in somebody who's hyperventilating is a condition known as carpal pedal spasm. They'll be breathing. Now they're blowing off all of their carbon dioxide. Well, what ends up happening is their lips go numb, their fingers start to cramp and spasm and bend, and their toes and their feet will actually start to spasm. This is called carpal pedal spasms, and this makes them worse. Now they get more excited, and they breathe even faster, and well, eventually Mother Nature is just going to hit the reboot button, and what's going to happen to this patient is they're going to pass out and they're going to stop breathing. Not forever, but for 30 seconds, maybe 45. Think about the genius of this. You're hyperventilating. You're blowing off too much CO2. You're becoming alkalotic. Mother Nature doesn't like it. So what does she do? She punches you in the face. You pass out and stop breathing. Well, cellular metabolism is still taking place. That hasn't changed. So what are you slowly building up while you're not breathing is more acids. Once your body reaches a state of homeostasis where it's happy with how much acid it has, well, poof, you start breathing again and you wake up. That's hyperventilation in a nutshell. And that's metabolic and respiratory acidosis and metabolic and respiratory alkalosis. It doesn't have to get too much more complicated than that. It really doesn't. All right, let me pull this slide off. And let's move on. Let's look at one of my favorite topics. I love talking about this next one. Let me get to my next slide here to make sure I stay on track. Let's talk about hypoperfusion. I like hypoperfusion. Oh, sorry about that. I'm dropping things. I'm a mess over here. All right. I'm dropping things. Yes, it is just juice and water. And this is my little thing here. You ever see the movies where they go click, take or cut or whatever? I always wondered why they did that. Well, now I know, because of what I'm doing here. As I'm editing these videos, I have to try to figure out where I've stopped and where I want to put the next slide up. And I'm always trying. So now what I'm doing, you can't see it, but I'm doing this. And now when I edit it, I see the yellow screen. So I'm learning. I'm getting there. All right, so let's talk about hypoperfusion, aka shock. Everybody's in shock when you watch TV. Oh, this person's obviously in shock. And all right, look at the truest definition of shock. Right? Inadequate tissue perfusion. That's it. That's the definition of shock. I think it was Samuel Gross back in 1872 defined shock as the rude unhinging of the machinery of life. I just love the way that rolls off the tongue. It's just a cool definition. But shock really doesn't have anything to do necessarily with fluid loss. You don't have to be losing fluid to be in shock. So follow me down this rabbit hole. Again, bottle of water. Okay. Think of your body, from this point on, I want you to think of your body as a container. We are nothing more than a 5 to 6 liter container of fluid. It's all we are. It's a closed system. There should be no holes in it. If there are, well, then that's when we come into play. But let's imagine your body as a container. The fluid inside is your blood, and this little clear plastic bottle is your cardiovascular system. Under normal circumstances, your cardiovascular system is full of blood up to about here. That's normal. That's what we want. Well, let's pop a hole in this thing, or have it start to ooze or seep fluid, or maybe change the diameter of this container. We'll talk about those here in a second. Any alteration in this container, whether it be oozing, punctured, changing the size of it, is going to affect the amount of volume inside of the container. So what's one of the ways that the body can compensate for a dropping fluid level? Well, one of the things that we're going to talk about is vasoconstriction as a compensatory mechanism. So if we vasoconstrict, look what happens to the fluid level. It comes back to the top. Right? Now Mother Nature is happy. We're maintaining homeostasis. We're at a normal volume up here. Well, these compensatory mechanisms don't last forever. So eventually they're going to release, and your fluid level is going to come down, and it's going to come down even further, and you're eventually going to die if we don't keep the fluid inside the body and get them to the appropriate facility. So that's shock really in a nutshell. So let's go ahead and take a look at this next slide here. Right. Causes of hypoperfusion. Hypoperfusion equals shock. You either have a blood vessel problem or a hose problem, a pump problem, a problem with your heart, or a fluid problem, the amount of blood in your container. Those are the only three things that are really going to affect hypo or perfusion status, getting fluid, getting blood to your tissue, aka perfusion. So when we look at the different types of shock or different reasons for hypoperfusion, they are numerous. One of them is hypovolemic.
What are you going to do, bleed on me? I'm invincible! You're a loony. The Black Knight always triumphs! How about you?
And as we can see, he was bleeding out, and that's one of the many reasons for hypovolemia. But don't think of hypovolemia strictly as blood loss. Hypovolemia could be from vomiting, all right, a Family Guy, diarrhea, burns. One of the biggest things that happens with burns is we burn away our protein layer that keeps fluid inside. Right? Skin is nothing more than a barrier to keep microorganisms out and fluid and heat in. Keep it simple. That's what skin does for us, how important it is to us. And when we talk about burns in a later video, we'll get more into that. But when we talk about hypovolemia, it doesn't always have to be blood. With burns, we're losing plasma. So yeah, we are losing fluid. It's just not blood in the truest sense of the word. But then, of course, there's your truest hypovolemia from blood loss. You have cardiogenic shock. Somebody's pump is failing. The best way to describe cardiogenic shock is shock with rales. Rales being fluid in your lungs, pulmonary edema. These people look like they want to die because they really are desperately trying to die on you. These are sick patients. So we'll talk more about that in cardiology. Neurogenic shock or spinal shock, transection of the cord. Now we have blood vessel diameter issues. We're no longer able to maintain the container size. So instead of having a 5 to 6 liter container being our cardiovascular system and 5 to 6 liters of blood in that container, what happens now is because of spinal shock or disruption in the spinal cord, now that 5 to 6 liter container becomes 8 liters. But we only have 5 to 6 liters of fluid in that 8 liter container. So we are then suffering from what's known as relative hypovolemia. We are hypovolemic relative to our container size. It's also a type of what's called a distributive shock. So when we look at anaphylaxis and sepsis, anaphylactic shock and septic shock are two different things. Anaphylaxis is because of an extreme allergic reaction, and sepsis is because of a microorganism, an infection, a systemic infection. But both kind of act the same way on the body to where they create leaky capillary syndrome. Remember we talked about leaky capillary syndrome. It also creates blood vessel dilation, which is going to increase our container size, same thing as neurogenic. So when we talk about different types of shock, Those are the main bulk categories. There's a lot of different types of shock, but those are the big bulk categories that we talk about. So what I want to do now is look at these equations on the board or on the screen here. These equations are something that I have been preaching for years. Every class I've ever taught, when I start talking about hypovolemia and shock, I almost always have these equations up on the board. And what these equations mean and can always come back to describing your hypoperfusion or your hemodynamic status. So CO equals SV times HR. Cardiac output equals stroke volume times heart rate. Okay, what's stroke volume? Stroke volume is the amount of blood ejected from the ventricles with one contraction. I'm not going to put a number on it, but the amount of blood pushed out of the ventricles, the volume of blood pushed out of the ventricles with one contraction is your stroke volume. Okay, well, the leading contributing factor to stroke volume is your preload. And by definition, preload is end diastolic volume. So the amount of blood in your ventricles at the end of diastole, all right, it's also known as end diastolic volume. This is preload. So the leading contributing factor to stroke volume is preload. So cardiac output is stroke volume times heart rate. So let's talk about drugs just for a quick second and how it can affect this. So when we're talking about nitroglycerin, as an example, we talk about nitroglycerin as being a vasodilator. So if we vasodilate, what we're doing is we're making the container bigger. We're taking a 5 to 6 liter container and making it maybe 7 liters. I don't know, just rough numbers, give or take. But your volume hasn't changed. So you still have 5 to 6 liters of fluid bouncing around in a 7 liter container. Well, what does that do to the preload of the heart? Well, it decreases it. So by decreasing preload, what are we doing to our stroke volume? Well, we're decreasing our stroke volume. Okay, what does that do to our cardiac output? Well, it brings it down. We'll look at the next equation, blood pressure. BP, blood pressure, equals PVR, peripheral vascular resistance times cardiac output. What's peripheral vascular resistance? Hydraulics 101, right? Narrow diameter hose, high friction, high pressure. Larger diameter hose, lower friction, lower pressure. Okay, so think about putting your thumb over the end of a garden hose. What happens to the harumph of that water coming out of the end of the hose? Well, it really kicks up quite a notch because you've narrowed the lumen, all right? You're restricting the vessel size. So if we have peripheral vascular resistance increase or resistance in that, or decrease in the diameter of that hose, well, we're increasing the resistance. By increasing the resistance, we're increasing pressure. So if we give nitroglycerin, what are we doing to PVR? Well, we're dropping it because we're vasodilating. Well, what have we already done to the cardiac output by giving nitroglycerin? Well, we've decreased it because we reduced preload. So what happens to our blood pressure? Well, it goes down. So what are one of the contraindications to giving nitroglycerin to our cardiac patients? Hypotension. If we give somebody who's already hypotensive nitroglycerin, what are we going to do with them? We're going to bottom them out. We're going to do them a lot of harm. So as a normal side effect, nitroglycerin brings down blood pressure. When we get into pharmacology, we're going to talk about different drugs, beta blockers, calcium channel blockers, ACE inhibitors, vasodilators, a number of different types of drugs on the market that actually bring blood pressure down. And we'll see, based on this equation that we have up on the screen right now, how these drugs actually do their job. So, when we talk about compensatory mechanisms for shock and how we compensate for shock, these equations become very important. So let's talk about heart rate for a second. And this is where the equation becomes a little counterintuitive. You would think, well, if somebody's tachycardic, well, their cardiac output must be higher. Therefore, their blood pressure must be higher. Not necessarily. Let's talk about a condition known as SVT, supraventricular tachycardia. Under normal circumstances, we have a heartbeat of anywhere from 60 to 100 times a minute. All is well with the world, life is good, 60 to 100. Those of you who are extreme, I shouldn't say extreme athletes, but very physically fit, maybe it's lower than that. And that's fine. doesn't mean you're dying. We're going to see that here in just a second. So let's take a normal heartbeat of 60. All right, beating away, doing its thing. Life is good. How much time is there for the ventricles to refill? Right, plenty of time, which is good. So that means we have plenty of preload. Therefore, we have plenty of stroke volume. Therefore, our cardiac output is just fine. Therefore, chances are our blood pressure is just fine. Well, now let's speed it up. Let's say we're at a heart rate of 200. All right? How much filling time of the ventricles is there? Well, very little. Well, therefore, what is our preload? Our preload is crap. Well, therefore, what's our stroke volume? Well, our stroke volume is crap. Therefore, what's our cardiac output? Crap. What's our blood pressure going to be? Crap. A lot of crap going on here. So heart rate does play a role, but it's all relative. Same thing holds true with somebody with a heart rate of 40. Now, again, if you're an athlete and you're normally at a heart rate of 40, your heart is very strong. So your end diastolic volume is going to be greater because there's greater filling time in between beats. Okay, that's perfectly understandable. But now, does your heart have the strength to be able to squeeze that additional volume out? If you're athletic, the answer is yes. This is why you can have a low heart rate, be somewhat bradycardic, and still maintain a good cardiac output because your stroke volume is just fine. Well, let's say you're 80 years old, you have an underlying cardiac condition, and your heart rate is 40. Your heart isn't strong enough to beat and squeeze that blood out. That runs into a lot of problems. So it's all relative. So albeit you're looking at somebody and their heart rate is 32. The oldest I've ever had a patient, I think she was in her mid-80s. She had a heart rate of 28. She was just fine, right? Mentation, normal. Skin color, temperature, normal. Everything was normal, but her heart rate was 28. Of course, I treated her and I didn't get crazy with her, but I took her to the hospital, but there was nothing for me to do because she was hemodynamically stable. So what I'm trying to get across to you here is treat your patient, not the numbers. So albeit your heart rate may be 30, look at your patient. One of the first organs affected by hypoperfusion is your brain. So if your patient's getting goofy, altered mental status, sense of impending doom, lethargy, whatever, that's a sign of cerebral hypoperfusion. That's bad. Well, then they start to become cool, pale, diaphoretic, and we're going to talk about that here in a second when we get into different compensatory mechanisms. So let me go ahead and pull this screen down. All right. So now we've got those equations in our head, and we understand how cardiac output and stroke volume and heart rate and blood pressure and peripheral vascular resistance all play a role in how we maintain our blood pressure and our perfusion status. Remembering, again, of course, the amount of volume in our container and the container size. Try to keep this in mind as we move forward. So when we talk about compensatory mechanisms, these negative feedback mechanisms, and we alluded to this in the last video. Again, it's a method to my madness. When we talk about fluid levels, and we talk about how the body senses fluid levels. Last video, we talked about baroreceptors. And we talked about how these baroreceptors are going to sense volume changes, pressure changes. We talked about osmoreceptors and osmolarity, and that's true of dehydration and a few other things, but we're going to get away from that now for a second and talk more about chemoreceptors. So when we're talking about hemodynamics, and we're talking about shock, and we're talking about hypoperfusion, we're talking about baroreceptors, sensing pressure, and chemoreceptors, sensing the pH of our body. All right, are we getting more acidic, alkalotic, and how is the body going to compensate for that? So let me go ahead and throw this slide up here. Let's take a look. Baroreceptors and chemoreceptors. All right, baroreceptors sensing pressure, chemoreceptors sensing pH. So let's take one step back. We pop a hole in that container and we start to leak fluid out. Well, what are the baroreceptors going to do? Well, the baroreceptors are going to say, hey, we're dropping fluid somewhere. Our volume is getting low, our pressure is getting low. Okay, let's send a signal to the pituitary gland. Pituitary gland sends that signal to the kidneys. Hey, hold on to sodium. By holding on to sodium, we're holding on to water. Great. Kidneys react, right? Kidneys are very sensitive to pressure changes. It releases renin. Renin goes to angiotensin 1, angiotensin 2. We start to vasoconstrict. We start to hold on to more fluids because of the release of ADH, antidiuretic hormone. So at the baroreceptor level, we are vasoconstricting, right, squeezing that bottle, and we're telling the body to hold on to fluid by holding on to salt. Perfect. At the same time, we have chemoreceptors, because what's going on in the body when we're starting to become hypoperfused, we're starting to now produce more acids because some of the cells in our body aren't being oxygenated, hypoperfusion. Well, what are these cells starting to suffer from now? Is they're starting to suffer from anaerobic metabolism. They're starting to produce lactic acidosis, which means our pH is going down, right? Our hydrogen ions are going up, our acid levels are going up, and we're starting to suffer from metabolic acidosis. Well, the body doesn't like that. So chemoreceptors send a signal to your brain, your midbrain, to say, hey, start picking up the respiratory effort here. Help me blow off some of these acids. And that's what the body does. We start to breathe harder and breathe faster, and we start blowing off some of these acids in an attempt to bring the pH back to a normal level. So when we talk about compensatory mechanisms in the body, the renin-angiotensin-aldosterone system is a huge player in that. Our chemoreceptors are a huge player in that. This is how the body reacts and how the body tries to compensate. One of the other ways the body compensates is really pretty wild. As we get to be, sick, like really sick, getting towards the point where it's irreversible shock, to where there's not much more we can do, the spleen actually discharges, squeezes about 300 cc's of fluid into general circulation. It's a little too little, a little too late. It's worthless. It doesn't work for the human body. In animals, it actually provides quite a bit of compensation for hemodynamic compromise, for shock. But in humans, it really doesn't do a whole lot of anything, which is sad, but very, very true. So let me go ahead and pull this slide off. And let's just back up a little bit. We talked about a few different things in this video. Let me go ahead and reference my notes here to make sure I'm on track. We talked about electrolytes and the four big players. We talked about sodium, potassium, calcium, magnesium. And just a side note on that, in the chemistry world, electrically speaking, all these electrolytes follow each other. So potassium follows sodium, calcium follows potassium, magnesium follows calcium. So you can't just replace potassium. You have to replace sodium and potassium. You can't just replace calcium. You have to replace sodium, potassium, and calcium. So it's not something that we're going to play around with pre-hospitally. Again, it's not what we do. In the chemistry world, it's pretty wild how it works. But needless to say, and to generalize it, sodium is big for electrical conduction system. Potassium is big cardiac and electrical conduction system. Calcium is big for muscular contraction, as is magnesium for smooth muscle reactions. So they all play a role, but it's at the pre-hospital level is not a lot for us to really worry about. We talked about acids and bases, metabolic and respiratory acidosis and alkalosis. We talked about normal pH, 7.35, 7.45, and the compensatory mechanisms to keep us there. That's the trick, is how to keep us in that homeostatic balance. Remember, one side or the other, just a little fluctuation can really create some devastating effect. So we talked about cellular breakdown. We talked about breathing and blowing it off. We talked about the renal system and peeing it out days later. So it's pretty wild how the body does that, which led us into hypoperfusion, remembering the bottle, right? This is us. This is our cardiovascular system and our blood inside. This is how we compensate, or how we think about our body and how we think about compensation in hemodynamics. Think about that container, think about the fluid in the container, and think about how when we vasoconstrict, we bring that fluid back up, how we hold on to fluids because of the renin-aldosterone-angiotensin system, ADH secretion, and now chemoreceptors coming into play to where we're telling the brain to start breathing faster to blow off more acids. Because in an acidotic environment, oxygen doesn't bind to hemoglobin, which is bad, which is going to contribute to our lactic acidosis production. Our blood vessels start to dilate, which is bad because of those equations, right? Now what happens to our cardiac output? It goes down because our preload goes down. Acidosis is also going to have an effect on those capillary beds. Remember, we start to pull apart those epithelium, and now we start third spacing fluid out of this container, and now it's starting to ooze out of this container, and our fluid level is dropping. And it just becomes a cascade of these horrible, horrible events. How do we mitigate this pre-hospitally? How do we identify it? How do we think about it? Stop the bleeding, oxygenate their patient, even if it's just by opening their airway, and get them to a surgeon. That's what people in shock, or get them to a hospital. That's what people in shock need. So the different types of shock, we talked about hypovolemic, cardiogenic, neurogenic, anaphylactic, septic. We'll get more into those later on. But at the end of the day, shock by definition is inadequate tissue perfusion. Our job, keep the fluid in the container, keep that container oxygenated as best we can, and get them to a hospital. It's really what it all comes down to. Okay, I think we've covered just about everything I wanted to cover today, and that brings us to the end of pathophysiology. I'm getting better at this. I'm right at 45 minutes now, so it's good. We're on time. I don't want to go much more than that. The next video is going to be pharmacology part 1, and we're going to review the neurological system in pharmacology, because we have to understand neurology, we have to understand anatomy and physiology, we have to understand pathophysiology before we can understand pharmacology. I've been teaching this for 1 or 2 years, so I'll lead you to the bear. I won't let the bear get you. Trust me. Follow me down this rabbit hole as to why I'm putting certain things in a certain place, and it's to help things make sense. Because now as we start to get into pharmacology, we're going to be tossing around terms about how the nervous system works, how the body compensates, diffusion, osmosis, so on and so on and so on. And pharmacology is going to be a little bit easier for you now. Hope you enjoyed it. I have. I'm starting to really enjoy doing these videos, so hopefully we can keep it going. You guys are keeping me motivated by emailing me and giving me your comments. The code word for this video is badge, right? Like a badge you would wear, all right? That kind of badge. See how you can work that one into a sentence. That should be fun. I think that's it. It's actually Friday, so I'm going to edit this over the weekend, and I will post it on Monday, Tuesday morning. Everybody have a great weekend. Be safe. Be COVID-free, and we'll talk to you soon. Take care.